Hello and welcome to another podcast. Today we're going to continue with medications and we're going to look at everybody's favourite, ibuprofen. Now the PCCM, as you would imagine, has one indication for ibuprofen, and that is the use in moderate pain. Now it does specify that it can be used by itself or in conjunction with paracetamol. Now I completely understand that most people feel that they are quite comfortable with ibuprofen. It is a very popular drug. It is readily used, readily prescribed, and is also known as over-the-counter drug. Because of this, it has had a lot of research done to it, and there has been a lot of problems and cautions that are associated with it. One of the major ones is it's linked to gastrointestinal effects. Now in the US, European countries and Australia, the presence of peptic ulcers and heightened acidity has been linked to leading causes Helicobacter pylori and the incorrect use or misuse of non-steroidal anti-inflammatory drugs. Most commonly used is ibuprofen. So they brought out a chart that most people will be quite surprised of. So on the picture that you see in front of you, it's got, first picture top left is a group of medications that if someone is taking these medications, then they automatically get a point or an increased risk associated with GI effects if they take ibuprofen as well. If they take two, then they're pretty much at the limit in which you should be giving ibuprofen. Okay, now another drug that's not mentioned there is lithium as well. If someone has a H. pylori infection, now most people who have a history of peptic ulcers, 90% of them will have Helicobacter pylori, but this is an active infection. Anyone over the age of 65, anyone that has a severe illness, okay, severe enough to actually cause chronic inflammation, is enough to have GI problems. Alcohol and drugs use, that's it. Alcohol and tobacco use, not misuse or anything like that, just using it. If you're using any other NSAID, and if you have a history of peptic ulcers. Now if you have just one of these and just one of the drugs, then they say that ibuprofen is fine to have at the recommended dose. But if you have a combination of two, or even more than two, then the uses of non-steroidal anti-inflammatories need to change. And certain anti-inflammatories will actually have an increased risk or relative risk of causing GI problems. Now since we're talking about ibuprofen, is just with two of the pictures on the screen, you have an increased risk of gastrointestinal problems. So if somebody is an alcohol and tobacco user, then they automatically have an increased risk. If they're taking one of the medications, then that's a risk as well. So we need to question our patients in order to get a good understanding of their body before we just willy-nilly administer ibuprofen. Okay, let's move on and we'll talk about the pharmacokinetics of ibuprofen. Now surprisingly enough, this is actually the one that all the ads you've seen has an element of truth connected to it. So the pharmacokinetics for ibuprofen is pretty much spot on if you say that it targets the site of pain. So it's rapidly absorbed and it has an 80 to 100% bioavailability on the site with an onset of 30 to 60 minutes. Okay, so very effective at targeting those particular areas. It is also incredibly protein bound, so it stays in the body for a extended period of time, hence the duration of 4 to 6 hours for each one. So when it says that it targets the site of pain, that's where the bioavailability comes in. So the site in which prostaglandin is being produced and causing that pain response is where ibuprofen will actually go to. However, if you are fooled by buying ibuprofen back pain or ibuprofen knee pain, then you're just wasting your money. You can get away with just buying ibuprofen because wherever the site is, that's where the bioavailability is going to be. Now it's metabolized through the liver, pretty much like everything, and over time it gets oxidized down to inactive metabolites. Now these metabolites will stay in the body for a fairly long period of time, and half of it will be excreted in the urine, and the other half will be excreted in the feces. Okay, going a little bit further in how ibuprofen works, we'll have a look at the pharmacodynamics. Now the pharmacodynamics of ibuprofen is all about cyclo-oxygenase, okay, or COX, or COX-1 and 2 in particular. So definitely those two, but it can actually be a few other ones as well. Okay, so these are what's known as isoenzymes. Now the way it works in the body is COX-1 is all about releasing the prostaglandin group that is about protecting your stomach, allowing for platelet aggregation and helping out renal function. Whereas your COX-2 side of the house, it releases the prostaglandin group. Now I'm using prostaglandins as the general term. There are specific mediators that are released, but for simplicity we'll just call them prostaglandin. Now half of those prostaglandins are associated with your inflammation, pain and your fever that gets produced by producing the chemotaxis trails that we'll look at. The other half looks at renal function again and tissue and vascular repair. Okay, so that's what that side of the house does. Now when ibuprofen comes along, it's what's known as a non-specific non-steroidal anti-inflammatory, and it will take out both COX-1 and COX-2. Okay, so on top of those two that it takes out, it may also inhibit chemotaxis that we spoke about, alter lymphocytic activity, decrease pro-inflammatory cytokine activities as well, and it also may inhibit neutrophil aggregations. Now all these effects, if it works, okay, it's not quite quantified, may also contribute to the anti-inflammatory activity, which is why they generally say ibuprofen is used as a greater anti-inflammatory as opposed to paracetamol, which is also classed as a non-steroidal anti-inflammatory. Now with these particular blocking of the COX lines, this is where we get our side effects from. This is where we get our bleeding problems from, with stopping of platelet aggregation. The GI cytoprotection is also broken down, so we don't get the protective layer around our stomach, which is where all our GI problems come from. On top of that, we can get a whole bunch of renal problems as well. Now, if you want more information on non-steroidal anti-inflammatories in general, you can have a look at the pain pharmacology presentation I've done in the past, and it gives you a overview of selective versus non-selective non-steroidal anti-inflammatories. But sticking with ibuprofen, we'll move on and we'll look at the enormous list of adverse effects and cautions. So starting with cautions, the big one is obviously hypersensitivities to most other non-steroidal anti-inflammatories except paracetamol, in particular aspirin. Okay, it's also very much, if you are working in a hospital and someone's had a cabbage surgery or bypass surgery, you don't give it as well. Now as far as cautions go, it's pretty much the same as when we get to interactions. Because ibuprofen is so readily used around the world, there's been thousands and thousands of independent studies on ibuprofen, which in turn brings up a huge list. Okay, so with great study comes great lists of cautions and great lists of interactions. Okay, so when we think about interactions, we just got to break them down to the main ones. So there is a quantified cardiovascular risk to do with lack of platelet aggregation, so bleeding, that sort of thing. Okay, so it can actually cause your bleeding problems, but then it could also has a slight increased risk of myocardial infarcts and thrombotic events as well, which can be fatal. We've already talked about the gastrointestinal risks. They're well understood. There's also associated risk with people with asthma, congenital heart failure, renal impairment, hypertension, bleeding disorders, lupus as well, ulcerative colitis, and shouldn't really use it in third trimester of pregnancy because it has had a link to closing the ductus arteriosus, which can be fatal for the baby because that's how they obviously transport their blood around after they get the oxygen from mum. Okay, so there's a huge amount of risk, including a risk of hyperkalemia in certain patients, especially with renal problems. So if you have a patient with GI history, third trimester pregnancy, strong asthma or cardiovascular history, ibuprofen can be a drug that is not recommended for these particular people. Okay, adverse effects, the main ones that you see outside of the huge risks, as your nausea, indigestions, GI bleeds, constipation is a much bigger quantified risk, even though your PCCM says that diarrhea is. Okay, I'm not actually sure where they got diarrhea from, because every other piece of literature mentions constipation. So I don't know, I guess look out for both. But we also have our CNS, your headaches, your dizziness, can get rash, and it can have ototoxic effects and cause your tinnitus. So nice long list of cautions and a big list of adverse effects as well. Now, just to make matters a little bit more complicated, because ibuprofen's been studied a lot, we have a lot of drugs, 380 drugs that are listed as quantified interactions for risks. Okay, now the main ones of those is pretty much any non-steroidal anti-inflammatory other than paracetamol. It is definitely aspirin, it is definitely your Voltaren, your indomethacin, all those. Okay, but paracetamol is safe to give with ibuprofen, hence why the pharmaceutical companies are now combining them and doing something that clinicians have done for a long period of time. Okay, so because of these massive interaction, it is always safe that if somebody is taking another drug, just check your interactions. Now, generally speaking, all other non-steroidal anti-inflammatories completely out, okay, or at high risk, but antibiotics, generally speaking, are safe. Okay, so just keep those general ones in mind, but always check your drug interactions, because I'm not going to sit here listing the 380 drug interactions, because no one will remember them anyway. Okay, we'll finish up with some clinical take-homes. Now, we talked a lot about ibuprofen. The reason we have is because I know it's a commonly used drug. Okay, the one we carry is an S2, which means we can give it any way we want. Now, I've gone through a lot of risks and a lot of adverse effects to ibuprofen. That is just to educate people, okay, that ibuprofen is not the safest risk-free drug that some people may believe that it is. So the bottom line is, don't be scared of ibuprofen. Don't be scared of medication. It has a use. It has a point. The point is to be educated and use it smartly. Okay, be clever by the way that which you prescribe or recommend ibuprofen. That is it. Other question is sometimes we're too easy to give drugs out. Okay, even when patients want them or not. Most people get given these simple pain reliefs and they end up sitting in a drawer for months. So questions that need to be asked is, can the patient actually handle the pain? Okay, and does that pain actually have negative effects? So is the pain impacting on their daily life? Because if it's not, then it's just pain. It's just a symptom of getting older, or sometimes a symptom of being in the military. Okay, you get a little bit of pain, and that's okay. These processes are in the body doing the tissue repair. Sometimes using non-steroidal anti-inflammatories can actually delay the repair of that tissue. Okay, so just think about when we're using it. It is used for moderate pain, which means it should be quantified as actual moderate, not that, oh yes, I do feel pain. Long-term ibuprofen use is not recommended. Okay, ibuprofen is supposed to be used for intermittent pain in the short term. Okay, we're talking 48 to 72 hours. People should not be taking ibuprofen long term, or those lists of adverse effects and cautions become more quantified. Okay, so ibuprofen should not be seen as an everyday drug. It should be seen as a selective drug that is used for a particular pain. That is it. Dehydration is a massive risk when using ibuprofen. Okay, now dehydration is a fact of life for soldiers as well. Okay, so if the patient is dehydrated, always tell them to take them with a large quantity of water and food if they're susceptible to GI problems. As mentioned, it is not recommended in pregnancy at all. However, some specialists may advise it. And what that means is you shouldn't give it to anybody who is pregnant, but if a patient is on it, prescribed by an obstetrician, then that's classified as a specialist. Remember, ibuprofen isn't 100% safe and doesn't play well with other drugs. So, check the interactions if your patient is on another drug. Now, if you're ever fortunate enough, unfortunate enough, whichever way you see it, to work with Americans, the Americans love ibuprofen. They absolutely love it, but their drug is slightly different. So they will give much higher doses than what is recommended in Australia, but their drug is slow release. Now, if you are working with the Americans, there's plenty of studies out there that show you the differences between non-steroidal anti-inflammatories used in Australia versus America. Now, the bottom line is the drugs have completely different pharmacokinetics. Because of the different pharmacokinetics, their absorption rate is different, bioavailability is different. A lot of the times, some are slow release versus rapid release. So you just need to be aware that they are different and they are not bioequivalents. Okay, that finishes up the lesson on ibuprofen. Hope you got something out of it. Hope you are not terrified of the use of ibuprofen and continue to provide good, clever care. But until next time, take care.